Well, thank you very much for that introduction. I don't have any relevant financial disclosures. And I think it is important to think about pulmonary embolism. We automatically jump to think about acute PE, but our experience here at Baylor is we've been seeing more and more chronic PE. So that's something I'll touch on at the end as well, because I do think that is a relevant topic. There's no shortage of data using ECMO for the management of acute PE. These are just a couple of case series. The top one is from my colleagues here at Baylor in Plano, published earlier this year. But there have been several large series, not necessarily randomized trials, but several large series showing the benefits of using ECMO for acute PEs. My goal is not to talk about data. A lot of it is retrospective and case series, but rather to talk about the nuts and bolts, the practical aspects of managing a PE patient utilizing ECMO. I think in terms of thinking about the general structure of how to approach a PE patient, we have those systemic treatments, including anticoagulation and thrombolysis. We have directed therapies, such as catheter-directed thrombolysis and thrombectomy, and then old-school surgical embolectomy, which is being used less and less. And ECMO serves as an adjunct to all of these. It stabilizes a very sick patient while the team can figure out which of these strategies to utilize. Now, in terms of stabilizing the patient and figuring out what the best strategy is, this is probably one of the best guidelines out there. It's from our European colleagues from a couple of years ago. And they even include, as you can see here, considering ECMO early, before you've even established a diagnosis of PE. This is based on the clinical presentation and echocardiography alone, before you've even done the CT angiogram, which is considered our gold standard. Either way, though, we definitely agree that after you've had some sort of attempt at reperfusion therapy, you can still consider ECMO then if you have an unstable patient. We've modified that a bit into, this is our current algorithm for Baylor Scott and White in Texas. And obviously a lot more complicated, but also includes very, I would say, low maintenance or least severe PEs, submassive PEs, and massive PEs. And as you can see, in the submassive and massive categories, there is a pathway in the algorithm which can lead to ECMO. One of the interesting things that I note about this algorithm, this has been in place for about 5 years, is CT consult for ECMO or open thrombectomy. And I think that that paradigm has shifted a bit, where it's not just CT surgery. There are intensivists, cardiologists, vascular surgeons involved in the ECMO team, and it becomes much more of a multidisciplinary team decision as to which of these pathways to go down. What's worked for us, and hopefully work with your institution, is the concept of a PERT, the Pulmonary Embolism Response Team. These patients are pretty complicated. If I go back to this algorithm, despite how complicated and how many different things are taken into consideration, very rarely do patients fit into one specific category. We try as much as we can to put them in one category and therefore determine the ideal management strategy, but most patients don't follow this algorithm, and that is where the PERT comes in for specialists from cardiology, surgery, interventional radiology, emergency medicine, hematology to all come together. What we've used is through our EHR, we have a chat group which has people from all different specialties. And a message goes out with the patient's link so we can all look at the scan, look at the clinical factors. And it sort of avoids the need to have an on-call person all the time, because whoever is on call is going to have access to that right away. If it's the middle of the night and you're not on call, you're not going to see it right away. But enough different specialties are on that we'll have at least 3 or 4 different disciplines making these decisions. Ultimately, in our institution, the pulmonary critical care doctor in the hospital is the gatekeeper for the PERT, and that's been incredibly useful. We just did a recent review, and we've had some great outcomes since we implemented this in 2018. The real goals of the PERT and of managing a patient with PE is, one, the immediate life-threatening problem, which is right ventricular failure, and the second is oxygenation. And these things play hand in hand. Some patients are going to have a much harder time oxygenating, but their hemodynamics may be okay until their oxygenation gets too bad. And other patients are going to have severe hemodynamic instability, but be able to maintain their oxygenation. So that's something to think about as we talk about the different utility of ECMO for these patients. RV failure is a specific interest of mine. It's really interesting, very different than the LV. The main difference when it comes to PE and to chronic pulmonary hypertension is that the RV is very volume dependent, and it does not tolerate changes in afterload. Something obstructing the RV, like a saddle PE, is going to rapidly drop its stroke volume and rapidly drop your cardiac output. The left ventricle can take a little bit more of a hit in terms of afterload and volume depletion, and can adapt, but the RV does not have that benefit. The second problem is that because of its compliance, the RV, as it becomes less and less dynamic, it can actually dilate a lot more than the LV can, to the point whereas when it's acutely distended, it'll begin to compress the LV, and that's where you get the real hemodynamic instability of decreasing your cardiac output. So a secondary problem of RV outflow tract obstruction, RV dilation, LV failure. And that is what kills these patients. The go-to for this problem in a very unstable patient has been and probably will always be femoral veno-arterial ECMO. Very specific about which vessels are being used, because when you're on the ground, you need to make those decisions. Are we using the veins? Are we using the arteries? Are we in the neck? Are we in the chest? This is femoral VA ECMO. This is sort of the classic depiction. We're going to drain the right heart through the right femoral vein, and we're going to turn the blood flow to the right femoral artery. I use the right preferentially because I'm right-handed, standing on the patient's right side. I can do that very quickly by myself. If you have multiple people involved, using contralateral limbs is one way to go. Other centers believe you should always stay on the same side. I don't think we really know the answer to that. The considerations with putting somebody on femoral VA ECMO are essentially one, percutaneous versus open, and I think what that depends on is how urgent this is. Who is doing this? Some cardiac surgeons are more comfortable cutting down than percutaneously accessing the groin. Are you at the bedside in the ICU or in the emergency department, or are you in the operating room where cutting down and having surgical instruments is a lot easier and you have nursing assistants there? What is the body habitus like? Believe it or not, in morbidly obese patients, percutaneous, much easier than cutting down. How facile are you with ultrasound? As I mentioned, a lot of the old school cardiothoracic surgeons that I trained with certainly were not very comfortable with ultrasound. They just never learned how to use it. And finally, do you have access to fluoroscopy? If you're in a cardiac cath lab, you're very comfortable when you have that access to fluoro, but if you're in the ICU or the emergency room, you're out of your comfort zone. And all these things are going to factor into how you cannulate somebody. What's great about femoral VA ECMO is that it's rapid, it's very reliable, and very reproducible. It is the same thing every time. Most patients have within very minimal deviation, similar size vessels, so you can standardize which side of the patient you use, what size cannulas you use, what kind of flow you get, and stabilize that very unstable patient very quickly. But there are obviously some downsides as well, and bleeding being the main one. This is especially true in a patient that's already received thrombolysis. If you've just given TPA to somebody and now you're percutaneously trying to access their femoral vessels, let's say somebody very obese, somebody you don't have a good ultrasound view, there's CPR ongoing, this can turn into a groin hematoma, or worse, a retroperitoneal bleed. The second issue with femoral ECMO is that LV is not failing because of a congestive heart failure and underlying myocardial problem. It's purely mechanical. The RV has dilated, minimized your return to the LV, and therefore the LV fails. However, once you decompress the LV is going to recover very, very quickly. What that's going to lead to is something called differential hypoxemia. In the presence of persistent RV failure, you're going to have normal left ventricular cardiac output, but your RV is failing. And finally, if you keep a patient on femoral VA ECMO, ambulating them if they're on a prolonged course of ECMO is going to be difficult, not impossible, but difficult. We'll touch on these two topics here because I think they're very important in managing these patients. Differential hypoxemia, also called north-south syndrome, refers to the fact that as the LV starts ejecting, the blood that it's ejecting is fundamentally hypoxemic because you've offloaded the RV, number one. And number two, you're going to have a ventilation perfusion defect due to the PE, so you have relatively hypoxemic blood coming out of the lungs, going back to the left atrium, and being ejected from the left ventricle. However, femoral return from ECMO will give you hyperoxygenated blood, and you'll have this mixing cloud somewhere, and that may be here in the ascending aorta, maybe in the arch, and maybe in the descending aorta. The problem is going to be that your upper body, meaning your coronary arteries, and your head vessels, your carotid arteries, are going to be getting hypoxemic blood, whereas the rest of your body is getting hyperoxemic blood. This will happen, as I mentioned, as the LV has recovered, but the lungs and the RV are still suffering. The basic way out of this problem is adjusting your cannulation strategy to veno-arteriovenous ECMO. So this is a patient that's been cannulated in the left femoral vein and the right femoral artery. And an additional return cannula has been placed in the right internal jugular vein and spliced into the return side after the oxygenator. So now we're turning oxygenated blood to the right side as well. The goal here is to offload the RV as much as possible, but we're now returning some hyperoxygenated blood to the lungs such that when the LV is ejecting, it is ejecting more oxygenated blood, and the brain and the coronary arteries can get as oxygenated blood as the rest of the body. This gets a little bit tricky because your return is split between an arterial vessel and a venous vessel, which have different resistance. And so we use this clamp here called the Hoffman clamp, but you can actually put a clamp on the tubing here, which will control your blood flow between the two limbs. And it takes a very fine balance between having hypotension, hemodynamic instability, and hypoxemia. These patients can be challenging to manage, but when you get it right, it's pretty satisfying. This is a patient that we cannulated in the emergency room. We ended up having trouble putting in a reperfusion cannula. We had to cut down and put it in directly, but we have a femoral drainage cannula, femoral arterial return cannula, and then we splice in a return cannula up to the right IJ for VAV ECMO. Solves the problem of differential hypoxemia temporarily as the lungs and the right ventricle are healing until that patient can safely come off ECMO. And as you can see here, many different ways to set this up, many different sites to drain from, to return from until you get it right. And this is a matter of comfort, what your team and what your center is used to. One of the things that I love about ECMO is that the sky's the limit. You can do many different things. The other issues with ambulation, there are some models where we can do upper body via ECMO. This was popularized by the group at Columbia called a sport model, where they would drain through the right internal jugular vein, put a graft on the right axillary or subclavian artery, and return that way. That way you have nothing in the groin. This is primarily used in chronic pulmonary hypertension, where patients are going to be on prolonged support, and we really need them ambulating. We've taken this a step further to what we call the super sport model, which is instead of just having a single lumen drainage cannula in the right IJ, we'll use either an Avalon or a Crescent, which is a dual lumen, or a Protect Duo, and drain both limbs so that we're offloading the right side completely, put both limbs to drainage, and return to the axillary artery. Maximal offloading of the right side of the heart. One company called Spectrum Medical came out with a new cannula this year. It's a dual lumen cannula like a Protect Duo, but it has an additional drainage port here to offload the RV even further. And then they went a step further to build a graft that goes on the axillary artery with a direct connection to the ECMO lines. We've used it once. I was reasonably satisfied with it, but I think it's a little bit early to really comment on its utility. And then finally, in terms of ambulation, you don't necessarily have to move everything to the upper body. Several centers have published good data on ambulating patients with VA ECMO through the groin. Takes a lot of training with your nursing and physical therapy team, but it can be done. So just to go back to our initial goals, VA ECMO is going to offload the RV as best as possible. But oxygenation sometimes is a bigger problem. There are times where your RV can be maintained, but your oxygenation is suffering. We've seen this mostly in our COPD patients, patients with emphysema or underlying lung disease who get relatively small PE. Their RV doesn't struggle, but they can't oxygenate. And this is where veno-venous ECMO can come in handy. We recently looked back and found of about 45 patients in our center with PEs that we put on ECMO. 5 of them were VV ECMO, and they were all COPD and ILD patients who had stable hemodynamics but couldn't oxygenate, and they did great. Actually, all 4 out of 5 of them survived the discharge with VV ECMO alone. So something to think about in the back of your mind if you're only dealing with an oxygenation problem with stable hemodynamics. So going back to these adjuncts for treatment, just a couple tips and tricks. We don't use the ECOS catheter that much anymore. This is an ultrasound-aided thrombolysis. I think we've found that it hasn't worked too well. We've moved on to mechanical thrombectomy. These are the 2 companies that exist right now, the Penumbra and Inari systems. In our center, and I'm sure it's different in every center, these tend to be preferred by the interventional radiologist and this by the interventional cardiologist. A couple good studies going on now. I think the key in terms of ECMO is we typically will have an ECMO team on backup if one of these devices is being deployed. It sort of depends on how complex that patient is, but stabilizing the patient with ECMO and then proceeding to catheter-directed thrombectomy, in my opinion, is probably the best strategy for a massive PE. And this is a good example of a pretty successful catheter-directed thrombectomy. Now, in the back of your mind also, some of those patients get a catheter-directed thrombectomy and it's unsuccessful. We rarely do old school surgical embolectomies anymore, but this is a recent case we had, pretty significant right PA clot. Went for a catheter for a pulmonary angiogram, and you can see in a minute here, no filling of the right PA. Attempted catheter thrombectomy, which was unsuccessful. And so we took that patient to the operating room. Let's see. And this is how we do a surgical embolectomy. We cannulate the right atrium and the ascending aorta. We mobilize the superior vena cava so that we're looking at the right pulmonary artery, make an incision in the pulmonary artery here where the clot is. which looks like this, and pull the clot out. And this is what a clot looks like in the right PA. I wish all of our clots looked like this. This is pretty fresh, reasonable clot. This is not my patient. Actually, this is the patient we had. It was pretty chronic appearing clot and some fresher clot more distally. So keeping the surgical option available is always important. And just as I mentioned in the beginning, don't forget about chronic thromboembolic pulmonary hypertension. ECMO can be used to stabilize these patients. Patients that come in crashing and burning can be put on ECMO as a bridge to an endarterectomy, or those that come out of an endarterectomy with right ventricular failure are often stabilized using ECMO. And finally, we recently had a patient which was a bridge to diagnosis, a young lady who came in, hemodynamically unstable, arrested. We didn't know why. We put her on ECMO, and then we were able to diagnose her with CTEPH. This is what her vitals look like. So she's got systemic PA pressures and she's hypoxemic. We put her on VA ECMO followed by VAV ECMO to stabilize her, and then took her to the operating room for an endarterectomy. And this has been used on both sides, as I mentioned, pre, intra, and post-op endarterectomy. This is just a quick video of how we do the endarterectomy here.
3 segments in there. Ongoing pulmonary artery.
So we're opening up the artery from the inside and cleaning out all that chronic appearing clot. And this is what it looks like on the specimen side. So that's sort of an overview of the use of ECMO for management of pulmonary embolism, both acute and chronic. If you have any questions, feel free to email me or text me at this number. And anybody that's interested, just email me. We have a monthly pulmonary thromboembolism conference. This is with our cardiothoracic surgeons, vascular surgeons, radiologists, pulmonologists, cardiologists, pretty much everybody. And we talk about complex cases we've encountered in the past month. Happy to invite anybody who would like to attend. If you have any other questions, feel free to reach out to me anytime.